I will now hear from Dr. Piero Perucca.
Thank you very much. Good evening, everyone. It's quite daunting to give a talk on epilepsy in 40 minutes or so. It's a big topic to cover, so I wanted to focus on important concepts, but also the field has moved forward considerably in the past few years, so I'll introduce new concepts and also share with you recent advances in the field. So this is the outline of my talk. We'll start with some definitions and move to pathophysiology classification, then touch base on the epidemiology of epilepsy, how should epilepsy be diagnosed, and then spend a fair bit of time on the treatment of epilepsy. So it's important to distinguish between epilepsy and epileptic seizures. And this is an important thing to do early on because epilepsy is really an enduring predisposition to have seizures. And as such, seizures are a symptom of epilepsy. However, seizures can also be isolated events. And as such, they may not be sufficient to make a diagnosis of epilepsy. So what is an epileptic seizure? Is a transient occurrence of signs and or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. Broadly, they are divided into focal seizures, which originate within networks limited to one hemisphere, as shown in Figure A, or generalized seizures, and these originate at some point within and rapidly engage in bilaterally distributed networks. So this is the first important novel concept that I wanted to share with you, and relates to a recent classification of epileptic seizure. As a matter of fact, this is a position statement, a position paper by the International League Against Epilepsy, which revised its classification of epileptic seizures as follows. So the broad classification of focal onset seizures, generalized onset seizures, unknown onset seizures, and then classified. Now, focal onset seizures can be broadly distinguished according to preserved awareness or not. So focal aware seizures or focal impaired awareness seizures. This can be subclassified according to motor phenomena, according to motor onset, and you see examples of those, and non-motor onset. And the seizure can evolve to a bilaterally convulsive seizure, and this is called focal to bilateral tonic-clonic seizure. So for those who are familiar with the older classification, focal aware seizure corresponds to simple partial seizures, whereas focal impaired awareness seizures corresponds to complex partial seizure. And focal to bilateral tonic-clonic replaces secondary generalized tonic-clonic seizures. So it's important that we get familiar with this terminology because this is what will be used from this point forward. Generalized onset seizures distinguished into motor. This include tonic-clonic, clonic, tonic, myoclonic, and non-motor or absent seizures. This can be typical, atypical, myoclonic, or islet myoclonia. Now, when we are unable to define whether the seizure has a focal onset or generalized onset, then we refer to the seizure as having an unknown onset, again, distinguish between motor and no motor, and then classify when there is sufficient information to classify the seizure in one of the three categories above. So that is where we are in terms of the epileptic seizures. What about epilepsy, which is the topic of this talk? Well, it's important to start with definition. So epilepsy is a disorder of the brain characterized by an enduring predisposition to generate epileptic seizures and by the neurobiologic, cognitive, psychological, and social consequences of this condition. Recently, at least 3 years ago, the definition of epilepsy is being revised to have a clinical impact, and as such, a practical clinical definition of epilepsy has been formulated. And this extends the classic definition of epilepsy, characterized by at least 2 unprovoked seizures 24 hours apart, to extend to the following 2 situations. a single unprovoked seizure and a probability of further seizures similar to the general recurrence risk after 2 unprovoked seizures occurring over the next 10 years. And that general recurrence risk can be estimated to be around 60%. Now, many of you will say, if we have a single seizure, how can we quantify that 60% risk? It's challenging. So that risk can be ascertained, or at least quantified in this situation. A single unprovoked seizure in the setting of a previous history of a stroke, a single unprovoked seizure in the setting of a previous history of a CNS infection or a severe head injury. So nowadays, we can make a diagnosis of epilepsy in a patient who had a stroke a few years ago and presents with a new seizure, obviously with that seizure being concordant with an origin from that stroke. And this, I think, it just aligns the official definition of epilepsy to the usual clinical management of similar case scenarios where we would typically treat someone presenting with that specific scenario. Obviously, if we can make a diagnosis of an epilepsy syndrome, independently of whether it fits the classic criteria, and obviously we can make a diagnosis of epilepsy. And the last important component of this new definition is that it includes not only unprovoked seizures, but also reflex seizures. So it's a new terminology. It's a new component of the new definition of epilepsy. Again, the classification has moved forward, and just a couple of months ago, the new classification of epilepsy has been made official. Again, this is an official position paper by the International League Against Epilepsy, which was led by a task force. The first author being here from Melbourne is Ingrid Scheffer. Many of you are familiar or will be familiar with that picture. And this really changes the way we look at epilepsy and the way we classified it. It starts with the seizure type. So based on the previous slide, we need to first classify the seizure type into focal, generalized, or unknown. Once we classify the seizure type, then we can move forward and classify the type of epilepsy. This can be a focal epilepsy, and this comprises focal seizures only. Generalized epilepsy, this includes only generalized onset seizures. Or here's the new class in this new classification, the combined generalized and focal onset seizures. Those clinical situations where patients will have both generalized onset seizures as well as focal onset seizures. And an example of this are the epileptic encephalopathies. Or unknown epilepsy types where we are unable to classify the epilepsy in one of those 3 categories. In this new classification, emphasis is given to the etiology of the epilepsy. And 6 broad etiologies are considered: structural, genetic, infectious, metabolic, immune, and unknown. Also important, and which allows us to separate the new classifications to previous ones, is the consideration of comorbidities, because these are often an important component in being able to classify the exact epilepsy syndrome, which is the natural next step. So once we have defined the epilepsy type, the comorbidity, and the etiology, we can move forward and define accurately the epilepsy syndrome. And this is important because defining the epilepsy syndrome allows us to select the most appropriate treatment. All right, the epidemiology of epilepsy. This is an old slide which I've been showing for some time, but it's still valid as a matter of fact. And broadly, we used to say that at least 65 million people worldwide are affected by epilepsy. The incidence may vary across countries and regions, but overall it's about 50 over 100,000 people per year. And this is a nice graph showing the classic trend of the incidence of epilepsy across the lifespan. Has a U-shaped curve with an incidence being highest in the first decade of life. This decreases and plateaus from the second to the 5th decade of life and then picks up again in the elderly. So epilepsy can affect anyone at any age. It's more common. It becomes more frequent in early in life and towards the end of life in the elderly. The lifetime prevalence is important. Now, epilepsy is the fourth most common neurological illness. It is the most common serious chronic neurological disorder. And this is a nice slide taken by the American website, epilepsy.com, which shows how frequent is the lifetime prevalence of epilepsy. It strikes 1 in 26 people in their lifetime. So 1 person out of 26 will develop epilepsy in their lifetime. This is high. So how do we diagnose epilepsy? The first important thing to keep in mind, at the back of our mind, is that there are many conditions that in fact can mimic epilepsy. This is just a short list, including some examples. But it's important to keep them at the back of our mind in the consideration of a patient presenting with suspected epilepsy. So what are the epilepsy mimickers? Examples are syncope, migraine, sleep disorders, such as parasomnias, movement disorders, vertigo, cerebrovascular accidents, or psychogenic non-epileptic events. And it's important to emphasize that why we need to consider epilepsy mimickers, because making a diagnosis of epilepsy can be more stigmatizing than a delayed diagnosis of epilepsy. Epilepsy remains a clinical diagnosis. And I think the most important slide, if you have to keep in mind, one slide in my whole presentation is this one. You need to put efforts into collecting a detailed history. History is key here, and it must be taken from the patient, but often patients will lose awareness during their events, will have no recollection of what happened. So it's important to get a good historical account from a witness. And if you're unable to speak to a witness at the moment, try to get that history in subsequent visits. Nowadays is the new generation of iPhones and new technology, and this is important because it translates to how can we improve the diagnosis of epilepsy, and homemade videos can make a great difference. Patients or their family members can videotape a classic event, show it to you, and that really helps in carefully assessing the patient in front of you. Clinical examination often is normal in most people with epilepsy, but there are certain types of epilepsy, especially in childhood, which do present with abnormal clinical neurological findings. It's important to also emphasize that patients will present to you with apparently the first ever seizure. I say apparently because that will be a convulsive seizure, but when you probe deeper into the history, you'll realize that that patient has been having seizures for a while. Those are often in the form of focal aware seizures, so formerly known as simple partial seizures, or focal impaired awareness seizures, so formerly known as complex partial seizures. And examples of this are episodes of intense déjà vu, with patients reporting déjà vu as to them a normal experience, but when you probe the history further, they will say, well, it's a very intense sensation. It's not fleeting. It lasts quite some time, several seconds to a few minutes. I'm very caught up in that feeling. This is what they usually tell you. It's frequent, so it doesn't happen once or twice a year. It can happen in clusters, and sometimes a blackout after a déjà vu, but who doesn't? This is what they tell you. Other forms of focal aware seizures can be a sudden, unexplained episode of fear or of emotional changes, olfactory hallucinations or gustatory hallucination, sick feeling in the stomach, a rising epigastric sensation, starting in the abdomen and rising to the throat, or brief episodes of language disturbances. These are pointers to focal seizures, but also generalized onset seizures can be insidious. And typically, this is the case of absence seizures, where people will say, look, in school they tell me that sometimes I just vague out for a few seconds, and the teacher is telling me this quite a bit, that I'm not paying attention to class. Or epileptic myoclonics, brief twitching or jerking, especially and it's typical of that being in the morning. Shortly after waking up, patients will brush their teeth and suddenly have their arm jerk or twitch, or having a cup of coffee or a cup of tea and then throwing that cup against the wall because of that jerking. So these are pointers that, in fact, the patient who presents with your first seizure, typically first convulsive seizure, has been having seizures for a while, and as such, the first convulsive seizure is simply the first recognized seizure pointing to the diagnosis of epilepsy. A number of tests which can complement and support your clinical diagnosis. The EEG, the electroencephalography, it's an important component of this. This can be in the form of a routine, so a 30-minute recording, or a sleep-deprived. Why is a sleep-deprived EEG important? Because with a sleep-deprived EEG, the patient will fall asleep typically during the recording, and in sleep, the chances of capturing epileptiform abnormality is greater. And in someone presenting with a first seizure, an EEG done within 24 to 48 hours of a seizure will reveal abnormalities in 70% of cases. If the routine EEG is abnormal, in those patients, a sleep-deprived EEG will detect epileptiform discharges in an additional 13 to 31% of cases. Sometimes things are difficult, and what I would like to emphasize is that a normal EEG doesn't rule out a diagnosis of epilepsy. The EEG findings only support a clinical diagnosis. And the clinical diagnosis can be challenging, and to have to be able to make an accurate diagnosis, you may consider admission of the patient for a prolonged video EEG monitoring with the aim of capturing typical events and seeing not only behavior on video, but also any concomitant changes on the EEG. It's important to perform neuroimaging, and a high-resolution brain MRI should be performed in all adults with suspected epilepsy and in all children except those with genetic focal or generalized epilepsy where a decision is made on a case-by-case basis. The etiology of epilepsy. For a long time, this has been the classic picture, and this has been the classic slide, and it's seminal work by Hauser and Kurland from Minnesota, and published in 1975. You can see that 2/3 of patients with epilepsy are classified as idiopathic. What does it mean? Is basically you can't find a cause of their epilepsy. Now, this was 1975. This was back in the days the MRI, the CT scan was not available, and a lot of those studies had access to post-mortem findings or early, in quote, imaging investigations. So in the third of patients where a cause could be identified, the most common causes were trauma, stroke, tumors, infections, and congenital lesions. It's 2017 today, and I think we can say that the landscape of the etiology of epilepsy has changed. And again, using a slide from Sam Berkovic, who's again an Australian product, and has done seminal work in understanding the etiology of epilepsy and the relevance of genetics in the etiology of epilepsy. I think we can support his new paradigm, his new concept, where idiopathic is an old terminology which we can leave behind and replace that with underline how the genetics play an important role in the etiology of epilepsy. There are different forms of genetic etiologies, and this can be classified into monogenic epilepsy. So there is one gene with a large effect, and as such, individuals carrying that gene will have a substantial risk of developing the epilepsy. To the epilepsy with complex inheritance, where there are multiple genes, each conferring a small risk to the development of epilepsy, maybe even with environmental factors. But the genetics do play a very, very important role in the etiology of epilepsy. Obviously, the advent of brain MRI has reshaped our understanding of the etiology, and we have been able to detect new lesions, and I'll show you a few examples of those, which are only detectable at brain MRI. And there's increased interest around autoimmunity in epilepsy, with autoimmune epilepsy being potentially a next frontier, although I do agree with Professor Berkovic in that this probably has is a small slice in the cake. These are examples of MRI detectable lesions only. This is the classic example of mesial temporal sclerosis. These are two cuts taken from the same patient. They're coronal cuts. On the right side is a T2, and on the left side is a T1 coronal, showing, as pointed by the arrow, an hippocampus which is smaller on the right as compared to the left. I think you can all appreciate that both on the T2 sequence as well as on the flare, but also the increased signal in that hippocampus. So that hippocampus is smaller, therefore atrophic, but also hyperintense and therefore gliotic. This is hippocampal sclerosis. What about the other emerging very important cause of drug-resistant epilepsy? This is focal cortical dysplasia, which is an abnormal, it's a malformation of cortical development in the form of an abnormal migration of brain cells to the cortex. This is an example of an insidious lesion called bottom of the sulcus focal cortical dysplasia, seen here in the left superior frontal gyrus. With that arrow pointing to that to the bottom of that sulcus, as you can see, the cortex there is not as crisp as in the other areas of the brain. There is blurring of the gray-white matter differentiation, and a tail, which basically represents neurons which fail to reach the cortex in their migration in the early stage of embryogenesis. And you see that same lesion on different sequences, and you see how, if you don't look carefully for that spot, which is driven by clinical and EEG information, you will easily miss it. All right, so the next important part of my talk is the treatment of epilepsy. It's important to emphasize that the mainstay of the treatment of epilepsy are anti-epileptic drugs. This is a slide that I think shows the progress in the pharmacological treatment of epilepsy. Up to the mid-early 80s, only a handful of anti-epileptic drugs were available. And some of these are still available, including valproate or valproic acid, carbamazepine, benzodiazepine, ethosuximide, primidone, and phenytoin. But it's been an explosion in terms of the development of new agents since the mid-80s. And there are many other drugs in the pipeline. So from the mid-80s to today, over 20 anti-epileptic drugs have been developed and introduced into the market, and there are many more in the pipeline. So the options for patients with epilepsy in terms of anti-epileptic drugs has never been so wide. Different medications can act on different targets. And here is a slide showing the main targets for all the drugs I've shown you in the previous slide. The most common targets you will hear are sodium channel or sodium channels, upon which many common anti-epileptic drugs such as carbamazepine, lacosamide, or lamotrigine act on. There can be modulation of the alpha-2 delta transmission, but also calcium channel blockage and GABA potentiation, as seen here in the left corner, listing several anti-epileptic drugs. Why I'm putting up this slide is just to mix things up a little bit and make it more confusing, as a matter of fact, because the next slide shows you that although there is a main mechanism upon which a single anti-epileptic drug acts on, in fact, each drug acts on multiple mechanisms of actions. And so there is substantial overlapping in the mechanisms across different drugs. And this explains why different drugs may have similar actions, but also similar side effects as well. So although drugs are developed often targeting specific mechanisms, things are never so clear and easy, and there's never a perfect relationship between a target and a drug. This is an important slide because it tells you that how important is the clinical assessment of the patient. You need to get the diagnosis right. You need to get the epilepsy syndrome diagnosis right. Because if you make that effort, then you can give the patient the best treatment. So anti-epileptic drugs, in fact, are broadly divided into three categories, at least this is what I try to do here. Those which are specific for focal seizures and focal epilepsies. Typically, these are typical examples are carbamazepine, phenytoin, oxcarbazepine, lacosamide. And there is a single one that acts specifically on absence seizures and is very effective on it. And drugs which are called broad-spectrum anti-epileptic drugs, which act on many different types, such as valproic acid, which are not as good and not as effective when it comes to treating focal onset seizure. That's specifically the case of valproate, at least. So it's important to get the right seizure type and the right epilepsy type. What are the general principles of anti-epileptic drug therapy? Again, I sound like a broken record, but it's important to emphasize that you need to confirm the diagnosis first and then determine if treatment is indicated. If treatment is indicated, you need to select the anti-epileptic drug with the best probability of controlling seizures with the least side effects. And it's important to optimize dosage. It's important, I cannot stress this enough, to take into consideration the characteristics of the individual patients and his or her preferences. What do we know in terms of the effectiveness of the first anti-epileptic drug? So seminal work by Patrick Quine and Martin Brody in early 2000 show that 50% of patients become seizure-free on their very first anti-epileptic drug. And 90% do so on low to moderate doses. So you don't need to load the patient with high doses. The first drug tried should target low effective dosages. There's another reason for this, is that if you target low effective dosages, then the chances of minimizing toxicity are greater. So this is a study where we compared using an instrument listing symptoms and signs suggestive of toxicity between patients who, in a patient group with new onset epilepsy, randomized, one group randomized to immediate anti-epileptic drug therapy, or randomized to delayed treatment. And patients were asked to complete this questionnaire with symptoms and signs suggestive of toxicity. And the composite scores did not differ between the two groups 3 months after enrollment into the study. Most patients who were started on medication were started at low doses. This means, in other words, that if you start a patient on their very first drug at low doses, the chances of experiencing toxicity are very low. So the ideal goal, seizure-free, seizure freedom, and no side effects. If this is the case, then continue and review the response regularly, reevaluate the need to continue treatment after 2 or 3 years of seizure freedom. This is the ideal case scenario. What about if seizures are uncontrolled? Well, you increase gradually the dose of that first anti-epileptic drug until you reach the maximally tolerated dosage. And this is important to keep in mind. What are the classic patterns of response to treatment? So I said earlier that 50% of patients become seizure-free in their very first anti-epileptic drug. Those who fail the first anti-epileptic drug and are placed on a second monotherapy have a 15% chance of becoming seizure-free. If they fail the second drug, now the chances drop to 10%. And any subsequent treatment you give has only a 5% chance of controlling seizures, which means that patients failing the first 2 drugs they ever try, provided that it's an appropriately chosen drug, have only 5 to 10% chances of having their seizures controlled. But this also takes us to what we define as being drug-resistant epilepsy. And again, this is work from Patrick Quine, who works here at the Royal Melbourne Hospital, chairing the task force of the International League Against Epilepsy Commission on Therapeutic Strategy. And they came up with this definition. So drug-resistant epilepsy is defined as failure of adequate trials of 2 tolerated, appropriately chosen, and used anti-epileptic drug schedules whether as monotherapies or in combination, to achieve sustained seizure freedom. And this is it's in light of that slide I showed you. So if you fail the first two drugs tried for epilepsy, the chances of becoming seizure-free ranges between 5 to 10%. So that's not very high. So what do you do in that scenario? Then, well, you try different drugs, but in patients who have focal epilepsy, I think you should consider early on, or suggest early on, alternative treatments, and specifically epilepsy surgery. So this is the last part of my talk. So what are the non-pharmacological therapies for epilepsy? The most important one by far, and the only one which yields a real chance of getting a patient seizure-free with a patient with drug-resistant epilepsy seizure-free is epilepsy surgery. So epilepsy surgery, in other words, is the most effective therapy for drug-resistant epilepsy, but it's not for everyone. The evaluation of a patient for surgery is not a straightforward process. It's quite complex. It relies on the definition of different regions in the brain. And these different regions are defined using different measures: electroencephalography, imaging, neurological examination, studying the semiology of a seizure. And from EEG, we can define what we call the irritative zone, which is the area producing this signature of epilepsy, which are spikes. This is a large area, as you can see here in green. It does overlap, but it doesn't overlap perfectly with the seizure onset zone, which is defined as the area from which seizures start on the EEG. This is different from the functional deficit zone, which is the area not functionally normal interictally. So it's an abnormality that you pick up on a neurological examination. And this is different from the symptomatogenic zone, which is the area producing the symptoms during your seizures, and the epileptogenic lesion. So having a lesion in the brain in someone with epilepsy doesn't necessarily mean that that lesion is producing the seizures. What you can see is that these different areas do not perfectly overlap. And certainly they do not overlap with the so-called epileptogenic zone, which is the minimum amount of brain tissue which, if resected, destroyed, or disconnected, then leads to seizure freedom. To date, there is not a single biomarker that can accurately define the borders of the epileptogenic zone. The process of post-surgical evaluation is a long process and involves different assessments. The EEG is first. A patient is required to be admitted for prolonged video EEG monitoring, aimed to capture seizures and defining where the seizures start, thanks to the information obtained from the EEG and the video. But then there is extensive neuroimaging assessment, including a structural brain MRI aimed at identifying a lesion, SPECT, which assesses the perfusion in the brain and the area involved in the generation of seizure, if imaged at the time of the seizure, will show increased perfusion. If imaged far away from a seizure, will show decreased perfusion. So what you need to do is subtract one image from the other, and that methodology is called SYSCOM. Then there is PET, and PET allows to assess the metabolism in the brain, and a PET performed far away from seizures shows an hypometabolic area where the seizures are supposedly arise. And then there is fMRI, which is important to obtain because allows to define the eloquent cortex. There's areas which you should be careful in resecting because they can lead to important neurological deficits, such as language, for instance. When these informations do not allow to accurately define the area from which seizures start, or when there are discrepancies, then one may consider an intracranial EEG investigation, placing electrodes inside the brain to record directly from the brain where seizures come from. This assessment can rely on different types of electrodes: depth electrodes, and as an example A, strips in example B, or grids. Strips and grids are placed directly on the cortex, and basically it's a scalp EEG recording directly from the cortex, as opposed to depth electrodes, which allow you to record from deep structures in the brain. We cannot cover the entire brain with strips, grids, or depth electrodes. So when you proceed with the plan of doing an intracranial EEG investigation, you have to have an hypothesis on where to place the electrodes. And that hypothesis is generated through the information obtained with the EEG, with the neuroimaging, and with the history. This is the classic example of a surgically remediable syndrome, which is temporal lobe epilepsy with hippocampal sclerosis. This is the same patient I showed you earlier, with seizures arising from the right temporal regions. As you can see here, this is a discharge developing over the right temporal area in the classic fashion as in temporal lobe epilepsy. The surgery for drug-resistant temporal lobe epilepsy is called anterior temporal lobectomy or anterior temporal lobe resections. This resects the anterior two-thirds of the temporal lobe in the dominant hemisphere, so where language is represented, the resection is smaller, so only 4.5 centimeters from the temporal pole, as opposed to the non-dominant hemisphere where you can extend the resection further back, including 6.5 centimeters, again, from the temporal pole. Why is epilepsy surgery effective? We know this not only by clinical experience, through observational studies, retrospective and prospective, but this was demonstrated with an unequivocal randomized controlled trial performed in Canada by Sam Weeb and published on the New England Journal of Medicine in 2001. Patients with drug-resistant epilepsy were randomized to immediate surgical therapy or deferred surgical therapy, with no changes in their medications, and no changes in medical treatment. As a matter of fact, should revise that because medication changes were allowed. So, in order to reflect classic clinical practice. And one question you may ask: if surgery is so effective, is it ethical to perform a randomized controlled trial of epilepsy surgery? The question is probably not, but this center had the ideal settings to do this. They had a waiting list for surgery of 1 year. So by doing this study, patients had the opportunity, after being assessed for surgery, to go immediately into surgery or stay on that waiting list and have surgery 1 year down the line. So when comparing the two groups and those who became seizure-free, you can see how well the curves separate right away after enrollment. So 60% of patients in the surgical group became seizure-free, as opposed to 8% in the medical group, which is in line with what I said earlier. What are the chances of becoming seizure-free when you fail 2 drugs? Between 5 to 10%, and that's exactly that. Doing surgery may lead to asymptomatic chordentropinopathy. This doesn't affect, in most cases, driving eligibility. As a matter of fact, it's completely asymptomatic. It is important, though, to perform surgery in somebody who's eligible, because surgery has the opportunity of stopping seizures, and uncontrolled seizures are associated with an increased risk of disability, morbidity, but also mortality. So one patient in the medical group experienced an event called sudden unexpected death in epilepsy due to the uncontrolled seizures, and this is the most important and common epilepsy-related cause of death. There are, in addition to resective surgery, there are also other types of surgery. These are palliative surgeries in patients with severe epilepsies, including corpus callosotomy, multiple subpial transections, or hemispherectomy or functional hemispherotomy performed in conditions such as Rasmussen encephalitis. So the 3 next therapies I will discuss are treatments which can improve seizure control, but have a very, very tiny chance or a negligible chance of making a patient seizure-free. First is vagus nerve stimulation. Stimulates the vagus nerve. So a reminder of anatomy: 80% of the vagus nerve is made of afferent fibers. So you stimulate the vagus nerve by placing your wires calling around the nerve. The nerve is stimulated, impulses go back into the brainstem, and from the brainstem spread to the entire cortex. That's the mechanism. We really don't know the specifics of how this treatment works. As I said earlier, VNS, or vagus nerve stimulation, can improve seizure control, but rarely gets you seizure-free. So this is a meta-analysis of the three pivotal trials of vagus nerve stimulation, as you can see in the graph. Close to 50% of patients with VNS achieved a 50% or greater improvement of seizure control, but less than 5% became seizure-free during the trials, which lasted only 3 months on average. Another form of stimulation in epilepsy which is gaining momentum is deep brain stimulation. So this is not only a treatment for Parkinson's disease, but it's emerging to be a promising treatment also for drug-resistant epilepsy. Again, as with VNS, I should emphasize it's for patients who are not candidate for epilepsy surgery or in whom seizures continued after surgery. So in epilepsy, the brain stimulation targets the anterior thalamus. Again, chances of becoming seizure-free are very, very tiny. And in this randomized controlled trial, the SANTE trial, patients were randomized to sham or active stimulations. As you can see from the two curves, they separate, not greatly, but in patients with the active stimulation, an improvement in seizure control was seen, with seizures decreasing by 40% compared to baseline. Only one patient became seizure-free during the study, and interestingly was in the control group, emphasizing the importance of having a control arm in any study looking at new treatment. Many side effects can occur with DBS. This was also the first study to do so, to look at this specific treatment option. So experience has improved in the field, and we're getting more experience in the field, and many of the side effects that you see listed here, such as depression, memory impairment, which, by the way, can be even associated with epilepsy itself, are decreasing. So better experience in implanting these devices can result in decrease of potential side effects. I also wanted to touch base on the ketogenic diet. The ketogenic diet, in fact, I should revise an earlier statement, is the first-line treatment for two specific syndromes. One is GLUT1 syndrome, and the other one is pyruvate deficiency syndrome. Otherwise, it's a treatment that, again, can lead to improved seizure control, but rarely leads to complete seizure control. This is a nice randomized controlled trial performed in children at Great Ormond Street in London, and showed how patients randomized to the diet experienced an improvement in their seizures. So the seizure frequency improved by about 40%, whereas the control group experienced an increase in seizure frequency. The problem with the diet is compliance. It's difficult to comply with a strict diet, and this is why new diets have been introduced to improve compliance, such as the modified Atkins diet. So I wanted to leave a few minutes for question, potentially, and just end up with a few bullet points. So number one, epilepsy is one of the most common serious brain diseases. Requires careful assessment. You really need to collect a good clinical history. Please, it's the only message you take from my talk. Get a good clinical history from the patient and a witness. It requires careful management. In that sense, antiepileptic drugs are the mainstay of the treatment of epilepsy. Epilepsy surgery is the most effective way to control seizures in drug-resistant epilepsy. And seizure freedom is achieved in a variable proportion of patients according to different factors: the type of epilepsy, the underlying pathology, the duration of follow-up. In patients with drug-resistant epilepsy who are not surgical candidates, stimulation and the ketogenic diet can improve seizure control. However, achievement of seizure freedom with these therapies is rare. So with this, I conclude, and I'm here to answer any questions you may have. Thank you.
We welcome any questions from the room here first. The microphones are open. Otherwise, we'll check with the remote sites, and we'll call for any questions from outside. Remember to unmute your microphone. Okay, we'll leave it at that. Please thank our speaker, Dr. Piero Perrucca. Thank you. Okay, everyone.